I am Dr. Saket Kant. I'm a consultant endocrinologist at the Max Hospital, Shalimar Bagh and Action Balaji Hospital in Delhi. Today, we'll be discussing a newly diagnosed type 2 diabetes patient with high baseline A1C, how to approach this patient. This patient is Mr. AB, 45-year-old male with newly detected type 2 diabetes who visited the clinic 3 months back with multiple comorbid conditions like obesity, hypertension, and dyslipidemia. He was initiated on metformin with advice for lifestyle and diet modification and visited again as part of routine checkup after 3 months. Physical examination had a BMI of 31 kg per meter square, a blood pressure of 120 by 70 millimeter mercury, and a heart rate of 78 beats per minute. His laboratory workup, however, showed an A1C of 8.5, which is way higher than what we want. eGFR of 80 ml per minute per 1.73 meter square, LDL of 80, HDL of 38, triglycerides of 200, which are somewhat on the higher side. A plasma glucose fasting PP was 180 by 280 milligram percent, both of which are on the higher side. The fasting target is 90 to 140. Whereas the postprandial target is between 90 to 180. Both of these were on the higher side. He was on metformin 1000 milligram twice a day, lisinopril 40 milligram, metoprolol 100 milligram, and atorvastatin 40 milligram once a day. Now, the problem in this patient is the high A1C. The patient has a lot of comorbid conditions and the patient is obese also. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes, which has been shown by UPPDS data. UPPDS demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10-year post-trial was apparent even though no difference in HbA1c levels between the intensive and conventional group was seen. Post-metformin, or when metformin is not suitable, a combination of linagliptin plus empagliflozin is being considered as an alternative first-line treatment. It can be an initial combination therapy that may be considered to achieve target more quickly, particularly in patients like these with high baseline A1C with post-fasting and post-prandial more than target, because linagliptin would increase insulin secretion in a glucose-dependent fashion and decrease the postprandials, whereas empagliflozin would act both on the fasting and the postprandial, and there will be control of both fasting and postprandial with this combination. So early combination therapy in type 2 diabetes makes a lot of clinical sense, a lot of reasons for that. Firstly, a meta-analysis has demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7% compared with metformin monotherapy. So for patients with A1c which is higher than 1.5% above the goal at diagnosis, both the American Diabetes Association and the European Association for Study of Diabetes guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established CVD, CHF, CKD, or whose weight is on the higher side, and we want to achieve a weight reduction in these patients with a low risk of hypoglycemia. EMPA-LINA combination with complementary mechanisms and the pleiotropic benefits may be a suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk for either ASCVD, heart failure, or CKD, or patients who've got established heart failure or chronic kidney disease due to the tolerability of combination in addition to the potential benefits of empagliflozin on cardiovascular and renal outcomes, and no increased risk of heart failure with linagliptin, as has been seen in a lot of trials. According to this study, early achievement of HbA1c goal, that is less than 7% with EMPA-LINA, could reach target HbA1c at 12 weeks compared to monotherapies. Now, HbA1c decrement by the combination of EMPA-LINA 25 by 5 milligrams has demonstrated 1.81% HbA1c reduction at HbA1c more than or equal to 8.5 at baseline. This reduction was seen at 24 weeks in metformin-treated groups. The benefits on glycemic control were maintained at week 52 in the metformin-treated groups, and a higher percentage of patients achieving HbA1c less than 7 were reported for combinations. The combination also offers a suitable component in the strategy to achieve target A1C without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. The risk of hypoglycemia is very low because SGLT2 inhibitors like empagliflozin have an insulin-independent mechanism of action, whereas DPP4 inhibitors like linagliptin cause a glucose-dependent insulin release, which also carries a very low risk of hypoglycemia. Add to this the benefits of empagliflozin on heart failure, CKD, some degree of benefit in non-alcoholic steatohepatitis, the weight reduction, some degree of blood pressure reduction with a very low risk of hypoglycemia, and you have a very good combination in your hand. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when they are used with DPP4 inhibitors, perhaps because of a better glucose control, although other mechanisms also remain under investigation. In summary, this combination, empagliflozin plus linagliptin, provides robust HbA1c reduction, a 2 to 4 times higher odds of patient reaching the goal HbA1c compared to individual agents, and a very low risk of hypoglycemia. Add to this the pleiotropic cardiorenal benefits and the weight reduction with a SGLT2 like empagliflozin, and you have a very good combination that can be a second line therapy for patients uncontrolled on metformin or intolerant to metformin. Also, the combination on a background of metformin targets almost all parts of the omnis octard. So this is a valuable addition in the pathophysiology-based holistic management of type 2 diabetes mellitus that has been recommended by a lot of guidelines, including the American Diabetes Association. Thank you.